Good afternoon. Welcome to another UCSF Medicine Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine here at UCSF. Welcome to our live audience in our department as well as throughout UCSF and our friends and our partner sites throughout the UCSF Health Network. As is our tradition, we'll post this video tonight at about 7:30 p.m. on YouTube, and our previous Grand Rounds have been viewed now more than 300,000 times. So seems to be a lot of persistent interest in this topic and these conferences. A few ground rules for everybody who's watching live. You see them on the screen. Put the Zoom window in full screen mode. If you have questions, type them in the Q&A box. My colleague Quinny Cheng is monitoring those, and we will try to get to a few of those during the question and answer segment. And I think that's it. So today's conference is divided into two main segments. The first is an update by Sarah Doernberg on treatments for COVID, including this week's big news, which is the dexamethasone study, which, as you know, came out via press release, harkening back to what we talked about last week with the new way that scientific information is reaching the public through preprints and press releases and Twitter. But the news was at least promising, and we'll hear from Sarah about that, as well as updates on other therapies, because a number of other trials have come out in the last several weeks. That segment will go from a couple minutes from now until 12:25 or so. And then we will transition to a second segment that will take us to the end of the session, which will be about 1:15. We have talked about many of the surprises in COVID, asymptomatic illness and transmission, thromboembolism, the multi-system syndrome in children, and more, which help illustrate the complexity of this virus and how much we still need to learn. In some ways, the latest surprise has been another mystery that has come to light just in the last several weeks, and that is the increasing recognition that a fair number of patients who make it through the acute phase of the illness continue to have lingering symptoms for weeks and sometimes months. So in that segment, we'll hear from two patients. They also happen to be healthcare workers and colleagues, but in this mode, they're going to talk about their clinical experience as patients. And then three researchers at UCSF who are studying this phenomenon from three different vantage points, clinical, epidemiology, and basic science. So that will start at about 12:25. I want to give you a quick coming attraction, so I'm particularly excited about this. At this moment, the best-selling paperback book in the United States, believe it or not, is a book that was written 15 years ago, and it was written about another pandemic that occurred 102 years ago. The book, of course, is The Great Influenza, and next week I will interview its author, John Barry, here, and that will be our entire hour that we do that. It's a fascinating book, and I hope you can join us. On to today's agenda, our first speaker is Sarah Doernberg. Sarah is Associate Professor in the Division of Infectious Diseases at UCSF Health, where she sees patients both in the inpatient and outpatient setting. She's also the Medical Director of our Adult Antimicrobial Stewardship Program, and was one of the absolutely essential players, particularly in the first month or so, helping us with guidelines and everything from clinical care to workforce to PPE policy. So today she's going to do an update on what we now know about treatments for COVID. So Sarah, welcome.
Thank you for having me. So the plan for today is that I'm going to start with just a brief overview of some of the treatment options that have come out in the last week or two, and then I believe we're going to do some question and answers. So the first thing I just wanted to talk about is the dexamethasone news, which I think is kind of the elephant in the room, the most exciting news over the past couple of weeks. And I wanted to start just laying the groundwork with what we knew before this past week. And you can advance my slide. So what we knew about steroids before Tuesday of this week were a few things. And there's been a lot of research into steroids for treatment of ARDS, as well as for treatment of viral infections in general. So the top row of this slide shows some of the downsides about steroids, and the bottom row shows some of the upsides. So what we knew before Tuesday was that steroids had been associated with prolonged shedding of virus for both MERS and SARS patients in relatively small studies. There was a large meta-analysis looking at observational studies of influenza that demonstrated increased mortality. Now, those were very heterogeneous trial or studies as far as what the interventions were, how far along in the illness those patients were, but kind of a signal towards increased mortality. And then many different associations have been made with steroids and various adverse events, including psychosis, hyperglycemia, hospital-acquired pneumonia, and other types of infections, which as an ID doctor, we always worry about. Moving on to some of the kind of pros for steroids, there was an observational study that came out of China fairly early in the pandemic, looking at patients who had received methylprednisolone compared to patients who hadn't. And they did some multivariate analysis to try to control for confounding, but there were some concerns in this study because it was observational, patients got a lot of co-interventions, that the benefit seen with methylprednisolone may not have been 100% believable given the risk for confounding there. But it did show a survival benefit in that small study. Fairly recently as well, there has been a publication of dexamethasone actually in early ARDS patients that was published in February of this year that also showed a survival benefit at 60 days for patients who had received dexamethasone. And these were patients with ARDS that had developed within the past week, so really catching patients early. About 50% of those patients did have pneumonia and another 25% had sepsis. So many infectious etiologies for the ARDS were studied there. I will note there are many studies, including other randomized trials, that have not shown benefit or have even shown harm for steroids in ARDS. So this is definitely a mixed bag of data. And then there was a kind of joint society guidelines from the Society of Critical Care Medicine and the European Society of Intensive Care Medicine that looked at the data and weighed the risks and benefits and actually did end up recommending steroids for early ARDS. So next slide. So this is kind of setting the stage for the data that we're going to spend a little bit of time to talk about, which is the recovery trial. Many of you likely heard the data that was released earlier this week in press release form. I'm going to go through the study design, which is a little bit complex, before we talk about what we do know from the press release and what we don't know still. So this is a very, very large study being done in the UK. It's an open label randomized trial of patients who are hospitalized with suspected or confirmed SARS-CoV-2. Patients at these centers can be randomized to receive either kind of multiple stages of treatment. So I'm going to go through the 3 different randomizations that can happen to each of the eligible patients, and it's a bit complex, so bear with me. So the first kind of group of randomizations, or randomization A, is taking patients and randomizing them to kind of standard of care, no additional treatment, or one of 4 different interventions. That includes hydroxychloroquine, dexamethasone, azithromycin, or lopinavir plus ritonavir. Now, the randomization scheme is to put patients 2 to 1 in the no additional treatment to each of the intervention arms. And it gets a little bit complex here because each center can opt which of those 4 intervention arms they want to do. So a center could opt not to do all 4 and just to do 1, 2, or 3 of them. So the randomization would be 2 to 1, or 2 to 1 to 1, or 2 to 1 to 1 to 1. And then to make it even more complex, for each individual patient, the providers can opt not to make them eligible for randomization into one of those arms as well, if there's felt to be a risk to receiving the intervention in one of those arms. So for instance, if you got a patient with cardiac disease, you might say, I don't want them eligible for hydroxychloroquine. So complex randomization scheme, and I think that's going to be important as we look at the data. The second thing that can happen for these patients is they can get randomized again after randomization A to either receive no additional treatment or to get randomized to convalescent plasma. And that's more straightforward in a 1-to-1 ratio. Next slide. So the last complex step of this trial is that patients who meet certain criteria, so those who have been in the trial for under 3 weeks, and who have more severe disease, and this is marked as having an oxygenation saturation of less than 92%, or needing supplemental oxygen, and having a high CRP. So this is catching the kind of cytokine stormy picture, the inflammatory picture, are eligible again to be randomized a third time, randomization C, to no further therapy or to getting tocilizumab. So by the time you get through all 3 randomizations, there are 20 different combinations of possible treatments that patients are eligible to have gotten by the end of all of this. The primary endpoint of this study is 28-day mortality. And they look at this by pairwise comparison of each treatment to the control group for that randomization. Let's go on to the next slide. So what we know now from this trial are 2 pieces of information, both of which have been released by a press release. So one is the hydroxychloroquine data, which was released about a week ago. And what they found here is that in the 1,542 patients who got hydroxychloroquine compared to the over 3,000 patients who got control, again, remembering they're randomized 2-to-1 control to intervention, the mortality was pretty much equivalent, 26% versus 24%. And this is all-comer mortality at 28 days. So that is part of the hydroxychloroquine data that I'm going to present this week, and a little bit more straightforward. And then what was released on Tuesday is the data on dexamethasone. And again, this was also released by a press release. So they had about 2,100 patients who received dexamethasone for 5 days versus 4,300 control patients. The data is presented in the press release in an interesting way. They actually present some of the subgroups first, but if you dig down deep, you can get to the overall benefit of steroids. So the overall benefit is about 17% of survival benefit for all comers who got dexamethasone versus the control group. For those who were on mechanical ventilation, there was the greatest effect size. So 27% mortality in those who got dexamethasone versus 41% in the control group. Those who needed supplemental oxygen also saw a pretty significant benefit. And those who were not on oxygen, they did not see a difference in mortality. The numbers needed to treat for this end up being fairly low in that you only need to treat 8 patients in the mechanically ventilated group to save 1 life. And for those who need oxygen, it's 25. So let's move on to the next slide. So I thought it would be interesting just to compare this to the remdesivir data, which I know has been reviewed at Grand Rounds in the past. But this is data from the ACT-2 trial that has been published in preliminary form in the New England Journal of Medicine. And I will note that this data is 14-day mortality. They have not yet published their 28-day mortality. So take this with a grain of salt because the time windows are different. But if you look at the mortality rates in the overall group, as well as those who require mechanical ventilation at baseline, you can see that they're quite different from the mortality rates that were noticed in the recovery trial. And that's going to be something that I think is really important to understand as we get access to more data. We can move on to the next slide. So I think that there are many questions that remain from reviewing this press release, and we really need the full data in published form, preferably peer-reviewed published form, to be able to fully understand it. So some questions that I really have include the timing of when the steroids were given as far as when ARDS developed, knowing that the earlier it's given, the more of a benefit that's been seen in other diseases. What were the co-interventions that patients were receiving? Because of the randomization scheme, it's possible that some of the groups were unbalanced as far as allocation into the convalescent plasma and ultimately tocilizumab. I'm particularly worried about the tocilizumab piece because the steroids might have damped down some of the inflammatory reaction that would have gotten people eligible to that group C and potentially made things unbalanced in a way that might confound these results. I would like to know about adverse events, about crossover. Remember, this is an open label trial. Understanding who dropped out, how many people dropped out in each group, comorbidities of the patients, and why the mortality rate was so different than what we've observed here and was observed in the Act 2 trial. So let's move on to the next slide. So I'm going to go over briefly what else is new, and then Bob and I are going to discuss some of this data in a little bit more detail. So this was a trial that came out now a couple of weeks ago on convalescent plasma. It was a randomized open label randomized trial looking at convalescent plasma, taking pretty high levels of neutralizing antibody compared to patients who got usual care. They stratified people into severe or life-threatening COVID-19 groups, and they looked at time to clinical improvement, meaning improving 2 strata on an ordinal outcome scale or getting discharged from the hospital. And when they looked overall at the population that was randomized, and they did have to end early because of decreased enrollment into the trial, they didn't see a difference in improvement between the groups that was statistically significant. If you look, the numbers suggest that maybe the convalescent plasma had a little bit more people who had a quicker recovery, but that p-value is not significant in this small study. What was notable, and I think should prompt further study, is that in the stratum with severe disease, the clinical improvement rate was much higher in those who got convalescent plasma at 91% compared to 68% in those who did not. And that was a significant result, and I think encourages further study in additional trials, hopefully in a larger setting. Of note, also, more of the patients in the convalescent plasma group had negative PCRs when tested 2 and 3 days into their treatment. So again, kind of biological plausibility of how this might be working. So I'm encouraged by this. It needs more study. Let's move on to the next slide. So the next thing I just wanted to circle back on is the hydroxychloroquine story. And this was a study that was actually a study of post-exposure prophylaxis for COVID-19 using hydroxychloroquine. So this was a pragmatic internet-enrolled trial that took patients who had exposure to COVID-19 within 72 hours, either in their occupation or at home. About 66% were healthcare workers. And they had to have been exposed either with no PPE on or with just a mask without eye protection. They were randomized to either hydroxychloroquine or placebo, which was mailed overnight mail to their house, and took the medication, and then they assessed for development of either PCR positive disease or a clinical syndrome that was suggestive of COVID-19. And if you look at the rates of the clinical syndrome plus PCR at 14 days, they were fairly equivalent. Notably, not that many patients actually got diagnosed with COVID-19, thankfully. So the rates of actually documented COVID-19 were quite low and equal between the groups at about 2.5%. And I will say that there is other data that demonstrates that symptoms are not 100% reliable in that they can miss people with COVID-19 as well as overcall people with COVID-19. So this trial did not show a benefit, but also had a really low rate of the outcome. So I think that is nearing the end of what I had to present. If you move on to the next slide. I'm just going to mention kind of my take on all of this, and I'm sure that Bob will have more questions for me. But first of all, I'm encouraged that randomized trials continue to provide really crucial information with how we're going to move forward through this pandemic. I am intrigued by the dexamethasone data, but we need more information. This is a complex trial. There's a lot of questions that remain, and I think before we really change practice, we need to understand the data a little bit more in a full publication. It will also be interesting to understand how this will fit in with remdesivir. Most of the patients in the recovery trial that are being reported on now did not have access to remdesivir because their 28-day outcomes kind of coincided with remdesivir coming onto the kind of more widespread market. So that will be something that needs to be studied moving forward. I think the data at this point is fairly convincing that hydroxychloroquine really should not be used for treatment or prevention of COVID-19 at this point. And the convalescent plasma data is encouraging and warrants additional larger studies. So thank you, and I'm happy to take questions.
Thank you, Sarah. That was terrific. That is a complicated study. So let's drill into it a little bit more. First of all, I'm a little surprised to hear you say need more study. We're talking about a drug that costs pennies, that has relatively low side effects for short-term use, obviously massive side effects for people who are on it chronically, and coming out from a very respected group. They've published their trial protocol. I assume that's where a lot of your information came from. And so if we wait 3 weeks for the publication, that's a whole lot of people receiving intensive care and oxygen all over the world. So you can sort of make an error pulling the trigger too soon, but you can also make it pulling it too late. So how are you thinking about that if you had a patient today in the ICU at UCSF?
Yeah, I think this is a really, really tough question, and one where there's probably not a perfect answer. But you're right, the risk of a short course of dexamethasone to any individual patient is probably relatively low. I think on a population level, if we misfire on data that has some issues or we don't understand fully, that might have implications over time in a large scale. But I think at this point, it's worth a case-by-case basis consideration. And I don't think that I would go changing guidelines across the board without understanding the data a little bit more fully, especially because our population appears to be quite different from the population being described in that study. Our mortality rate is much lower here. And so I just want to understand what other interventions, what else was happening in that population to be able to know if it translates into a patient coming into our ICU here.
So if
I will say that I'm being completely inconsistent because I'm taking their hydroxychloroquine data and confirming my pre-existing bias that it's not effective and we should put the nail in the coffin. So, it's not fully consistent there.
Yeah. And just to make that clear, the reason you might hesitate here, we're seeing a mortality rate among ventilated patients more on the order of 15 or 20%, not 40. So you're
Correct.
saying that if you had a 30% benefit, the number of lives that you would say would be smaller, and you worry about the risk in that. So when you go from 41 to 27, that's a lot of patients who are benefited. If you're going from 15 to 10, fewer, but still real.
Yeah, it's less that, because I think if I knew that there was definitely a mortality benefit in our population that was of the same magnitude, when we look at the data, that we would give steroids if that's what it ends up being. What I'm uncertain about is, will we see that benefit here in our population? Or is there something different about the population that we're taking care of that might make the treatment less applicable or only applicable to certain subsets of the population that we're seeing? Okay.
So let's say in a week the study comes out and it's pristine and it crosses whatever bar you have for goodness. How are you going to decide on remdesivir versus dexamethasone or both?
Well, I think there's no reason not to give both. It may be that certain types of patients will benefit from one more than the other, but we don't know that yet. And there's no reason to think that steroids will hamper the effectiveness of remdesivir other than concerns about kind of prolonged shedding of virus.
Yeah.
And so I would favor starting to study giving one, the other, or both, but it would be something that I think we can move forward with using both.
So as you think about other semi-analogous cases in infectious disease. Are there cases where, I mean, is the way you would tend to think about that, if both drugs have a 30% benefit additively, this is going to be more like 50-ish%, or it doesn't work that way and sometimes we actually see harm because of interactions we don't understand?
I think it's hard to say until you study it. There are some infections where we use steroids and treat the infection as well. You can think about something like COPD, but some of those antibiotics we're treating less true infection and more kind of the anti-inflammatory effect of those antibiotics. As I mentioned, steroids make ID people nervous, but if there is a benefit for the inflammation and then the survival benefit bears out, certainly we should push forward with it and then do the study of steroids plus remdesivir and see where things fall out.
So unlike remdesivir, steroids are available orally, they're cheap, and you can see a whole lot of people going out and starting to pop them like vitamin C. I assume you think that would be a bad call, but take us through the at least theoretical benefit of potentially using steroids earlier in the course of things, what this trial says, and if you think that people should not do that, maybe you should say that.
Correct. I think that is a bad idea.
Okay.
So we do not know from the data we have available what timing the patients got treated with. So we don't know at what time course in their illness they were treated with. We hopefully will get more information. What we do know is that people who did not require oxygen did not see a benefit from getting steroids. And there's no biological reason why taking steroids before you develop the infection, so as prevention, would be at all effective. And that I would highly discourage. It would put people at more risk for infection, if anything. I think the potential biological plausibility is decreasing the inflammatory response after you have the infection develop, preferably before it really sets in and you get to kind of the later stages of injury. So there may be a sweet spot in development that we get to, but we need to see the data.
Got it. One of the folks watching said, can you comment on any other potential therapies for early disease? It seems like everything that's coming out that's interesting and potentially exciting is all for sick people in hospitals on oxygen or on ventilators.
Yeah, it's a great question. And I think part of that may be that it is very, very difficult to catch outpatients ambulatory early in disease. That's just a hard group to study because you have to be there at the moment they get diagnosed to enroll them. But there is some hope, and there are some studies going on looking at convalescent plasma given early in disease. I think the monoclonal antibodies are another thing that would be worthwhile to look at administering early in disease, and likely will. That's going to be the next kind of phase of trials that are out there looking at some of these immune supporting interventions.
Right. Maybe my last question is, in the hydroxychloroquine study, you mentioned that you could be diagnosed either with a test or with a clinical syndrome. And I have to say, I had like a massive allergic reaction to hearing that, because in San Francisco, everybody who has a fever and a cough thinks they have COVID, and 97% don't. So it makes no sense to me to use clinical syndrome as a diagnostic criteria. Can you just talk that through a little bit?
Yeah, I think it's one of the downsides of the outcome of that study. And I think it has to do with the fact that testing has not been widely available everywhere throughout the pandemic and throughout that study. So many ambulatory people at various places were getting diagnosed clinically because tests were being saved for people who were in the hospital. But you are absolutely correct. It is neither sensitive nor specific. We know that many people have infections and may not have symptoms. And we also know that many people with symptoms may not have COVID-19. So it is an imperfect measure. Yeah,
but in terms of interpreting that particular study, I don't know if you could think this through, but does it bias you in one direction or the other? Does it say it's even less credible that hydroxychloroquine works, or it says we really don't know very much because a whole lot of people who were diagnosed as COVID didn't have it?
I think it would be more likely to bias you towards the null here. But if you look at the numbers that were diagnosed, they did have some people who got diagnosed with PCR positive disease. They also didn't see any benefit, though the power for that very low outcome might not have been there in this large trial. I think it's fair to say that there was no major effect seen from the hydroxychloroquine given in this study. And given the other data, I wouldn't favor using it at this point in time.
Yes, it seems like it's time for that one to go away. Let us quit and move on to our next topic. Sarah, thank you so much. That was terrific and the best explanation I've heard so far of this complicated study, but potentially a very important study. So thank you.
Thanks so much for having me.
Thanks. Let's shift our discussion to this group of patients with persistent symptoms, a group that I think first came to popular attention in Ed Yong's article in The Atlantic, where he dubbed the group long haulers. We're privileged to have two patients who have experienced different versions of this. And as I mentioned, they're also experienced clinicians, so they bring that context. So let me introduce them and introduce the rest of our speakers. The first is Coleen Kivlahan, who is a professor here at UCSF in family and community medicine. She's also executive medical director of primary care services at UCSF Health. And she now belongs to a select club, I'm not sure how small, I guess we'll find out, of people who have had not only protracted symptoms, but have tested persistently positive. And that's how Coleen came to our attention through an article in the newspaper about her. And she tested positive for nearly 90 days. Second patient is another clinical leader, but also a patient in this regard, is Cliff Morrison. Cliff is a former clinical nurse specialist and forensic psychiatry program director at Zuckerberg San Francisco General Hospital. I knew Cliff back in the day because he was really absolutely one of the leaders of our innovative approach to HIV patients and helped found and lead the first AIDS ward in the United States at San Francisco General. Cliff tested positive with COVID on April 8th, 2020, and is still suffering from some symptoms, which we'll hear about in a few minutes. So Cliff, thanks for joining us. After hearing from Coleen and Cliff tell their stories, we'll turn to three experts here who are actually studying this phenomenon. The first is Michael Peluso, who's a fellow in infectious disease at UCSF. Michael is studying HIV persistence and compartmentalization and understanding individuals with unique characteristics who have the ability to control their HIV. And like a lot of people who had previously studied HIV, they have repurposed some of their intellectual energy into studying aspects of COVID, including this, and he's taken a lead on the clinical study of these patients with persistent symptoms. The second expert we'll call on is Jeff Martin, who's professor and chief of the Division of Clinical Epidemiology and Health Services Research in our Department of Epidemiology and Biostatistics. Jeff directs our training and clinical research program, so is responsible for teaching many of us about epidemiology and biostatistics, and one of the main architects of the biostat curriculum for the UCSF School of Medicine. So as parent of a UCSF student, I thank you. He'll talk about some of the epidemiologic and design considerations in studying the question of people with persistent infection or persistent symptoms. The final expert is Tim Henrich, who is associate professor in our Division of Experimental Medicine at UCSF based at Zuckerberg San Francisco General. Tim's research focuses on the immunomodulatory, chemotherapeutic, and stem cell transplantation approaches to try to achieve a cure for HIV. And he's also been interested and has been studying persistent viral reservoirs, and like Michael and other people, has turned some of his attention to some of the extraordinary issues that are emerging in COVID. So with that introduction, thank you all for being here. And let's start with Coleen. And Coleen, tell us your story.
Very quickly, Bob, I was working in urgent care at UCSF on 2/22 and 2/29 and 3/3. So in March, early March, before there were tests actually, and encountered 5 or 6 patients in a row on each of those days with a non-productive cough and a low-grade fever, all of whom had significant comorbidities. And again, there was no testing during that time. We had only heard, at least in the outpatient side, about what was going on internationally. Within 3 days of exposure on the 3rd, I began with a low-grade fever and the classic chest tightness and cough that extended significantly over the next several days. And within 3 days of that time, my pulse ox had dropped significantly in the 92 range from 99, and my systolic blood pressure had dropped significantly as well. So I was in bed working every day, and bottom line quickly is that my viral titers were positive for human metapneumovirus and negative for COVID on the first round. And then within about 8 to 9 days after, I was COVID positive as well. So my assumption is that I was co-infected, but bottom line is that I was persistently positive for 97 days since that time. And I persist now with several symptoms. One of those, and the most disturbing actually, is the phantasmia. I have a persistent perception of smelling forest fires. So in addition to anosmia, I feel like I'm surrounded by fire. I'm not an anxious person by nature, but smelling that when you're going to bed is disturbing. After the SF Chronicle article, got about 150 emails from all over the country and the world, actually, and about a third of them had the same phantom smell. So anosmia continues, ageusia continues, and this intermittent chest tightness with recurrent cough. But otherwise, I'm back to work and doing fine.
And so your testing remained positive. How many goes?
Oh man, I think I had, like 10 or 11 of those tonsillectomy swabs, right? So had multiple swabs that were all positive. And the first negative was 4 days ago.
Let me just say to patients who watch this later on YouTube, we do not do a tonsillectomy swab. That's a metaphor. So that's okay. So you had a lot of swabs that were positive. Did you have antibody testing?
I did, and that was the antibody testing and the PCR. The antibody testing was positive about 4 or 5 days ago, and the PCR was negative for the first time.
Wow, well, congratulations. And how did your experts who you consulted with counsel you in terms of ability to go back to work and be around people and colleagues and patients when you were persistently PCR positive for 3 months?
Yeah, interesting question, Bob. So I was returned to work on April 9th while I was still positive, and told just to not test. After that, I'm in the CHIRP trial, and so I was tested in that setting, but didn't know the results. So I made an assumption that I was viral culture negative, hopefully, and not transmissible, but I didn't see patients. I saw lots of colleagues masked, but I didn't see patients. A lot of anxiety about that for me, actually.
Yeah, I'm sure.
That's now better.
I'm sure. Well, thank you for telling us your story. I'm glad you're at least starting to feel better. And as you said, the smell of fire, you've heard that from a lot of other
multiple people.
Yeah,
multiple people. I just got a call from one of the nurses actually who turned positive in the last 2 days, and she smells stale cigarettes burning.
Wow.
So an interesting smell.
Yeah, sure is. Okay, thank you. Let's turn to Cliff. And Cliff, thanks for being here. And go ahead and tell us your story.
Yes. I'm still working. I work in a healthcare facility. I'm the administrator. But certainly my nursing background has been extremely helpful. And when we first realized what was going on, I went ahead before we were even required to do so and locked down the facility that I was running and started daily taking temperatures of all the staff and all the patients. And we stopped the visitors, and we didn't allow any deliveries. Hey, we had everything left outside, and we went and picked it up. I tested positive on April the 8th. We had a patient that about 10 days earlier had spiked a fever. And so I immediately put him in isolation, and he wasn't having any other symptoms, and he didn't want to go to the emergency room. But over the weekend, he began to have some shortness of breath. And so I was on call, so I overruled it and said, send him to the ER, where he was diagnosed. He stayed there 3 days and then came back. So I spent, quite a bit of time with him, as did other staff, but we were all wearing masks. We weren't wearing gloves and other things, but we were all wearing masks. And right around that time, I started experiencing what I thought and all of my colleagues thought was just my usual seasonal allergies. I've always had really bad allergies, but hadn't had a problem in the last year. But each day it just kept getting worse. And then on the on the morning of April the 8th, I just felt so terrible. I just, for the first time, I was running a low-grade fever. It was 99.4, something like that. And but I just felt terrible. And so I called my doctor and said, is there some way that somebody can see me, or I'm going to go to the ER? And so he said he'd see me that afternoon. By the time I got to my doctor's office in San Francisco, my temperature was 101.8, and I was extremely short of breath. And just felt like that I had completely hit a wall. He, at that point, said, yes, this really looks like you have COVID. I want you to go home and quarantine yourself, and we'll go from there. And so that's what I did. And the timing was, for me, almost perfect, because by the next day, April 9th, I was so sick I could barely get out of bed, and continued to be sick for several weeks after that. And then, as I thought that I was beginning to feel a little bit better, the shortness of breath just continued. And so I was put on azithromycin to treat what they thought at that point was a bacterial infection. And after that treatment, I did begin to feel better. But here I am now, almost 10 weeks later, or 10 weeks later, I guess. And I still have lingering symptoms, and still have some shortness of breath. I have a lot of weakness still. I tire extremely easily. My memory is just shot. I can't remember people's names. I forget details. I had to relearn to use my computer. I was surprised at just how much from that cognitive standpoint that I felt that I had lost. In fact, I had described it to several friends as feeling like that I'd had a stroke. And but I am feeling better, and I am looking forward to returning to work at the end of this month.
Okay, great. Well, I'm glad you're feeling better. Did it ebb and flow, or this has just been, you felt crummy and you sort of stayed crummy? It sounded like you maybe got a little bit better with the azithro, and that made you potentially believe that there was a bacterial superinfection component to this?
Yes, it was. During the first 3 weeks, there was probably 7 to 10 days that I absolutely have no memory. I live alone. Luckily, I have a lot of colleagues at work that pretty much took care of me remotely. My next door neighbor works with me as well. And so he and his partner every day did FaceTime with me to make sure that I was okay. I slept with everything on the bed that I needed. I kept, blood pressure, temperature, all the things that I could document, 2 phones, so that if I needed any assistance, I could call someone. And people from work and my neighbors, all left food for me every day. And the strange thing was that I didn't have issues with smell or taste. The only thing was I had really, really bizarre cravings. I wasn't hungry at all, so I lost 22 pounds during that period. And so that was the good side of that. But I craved things like I wanted dill pickles. I wanted saltine crackers and cheddar cheese. And, it was, my friends and colleagues were laughing at me. They said, you sound like you're pregnant.
Right.
And so that's what I existed on, sorbet and watermelon. Highly, highly recommend watermelon. I realize it's very high in fructose, but I lived on watermelon for a month.
Wow. Okay. Well, thank you. And in terms of your testing, I don't know if Michael wants to tell us that, or you know, but were you positive at some point and then turned negative? And do you know about your antibodies?
Yes, I tested positive on April the 8th. And then in mid-May, I went to the Hayward Fire Department to be tested again, and they got back to me actually probably within just a few hours and said that I was negative at that point.
Okay. And have you had antibodies testing?
I'm not sure if they did the antibody testing when I was at the clinic or not. They certainly drew enough blood. So
Yeah. All right. And you still have your tonsils. That's
yes, I do.
Let's turn to Michael. Thank you. Thank you, Cliff. Really appreciate it. So Michael, you're going to tell us a little bit about what you've learned about this clinical syndrome. You've been seeing a lot of patients and maybe a little bit about the study that you've been doing as well.
Yeah, so if we could put up the slides, that would be great.
Yeah.
So on behalf of our study team, thanks a lot for this invitation and for the opportunity to participate in this discussion. I wanted to specifically thank Mr. Morrison and Dr. Kivlahan for sharing their stories, which are not uncommon. So I'm going to take a few minutes to tell you very briefly about our study, which is called LINK, including our key research questions and just some of the anecdotes about what we're hearing and seeing so far. This first slide shows the overall study schematic. So at the top is the population in the San Francisco Bay Area who are at risk for acquiring SARS-CoV-2, with individuals with active acute infection shown in light green and those with recovered infection in light blue. So those with early infection are eligible for our sister study, which was mentioned before. It's called CHIRP. That study is led by Dr. Suyi Lee and Dr. Dan Kelly, and they're doing some really innovative work around the epidemiology and immunology of the earliest stages of SARS-CoV-2 infection. Our study is called LINK, and LINK enrolls individuals who are recovering from acute infection between about 3 weeks out from their initial symptoms to a few months out from their initial symptoms. And these individuals are referred by clinicians throughout UCSF, throughout San Francisco, throughout the surrounding counties in the Bay Area, and many participants refer themselves after testing positive. We can enroll anyone who had a positive nasal or throat swab with SARS-CoV-2 PCR testing. And we see participants monthly at our clinical research center at San Francisco General Hospital. We see them monthly for a few months and then plan to see them quarterly for up to 2 years. And at each visit, we do a detailed medical questionnaire and collect a variety of biospecimens like blood and saliva. And then the bottom of the slide is just demonstrating that there are many, many co-investigators and collaborators across both CHIRP and LINK. And I'm just identifying a few of them here. This is really a cross-departmental and cross-divisional effort with great support from the Department of Medicine and the infectious disease divisions at UCSF and SFGH. Next slide, please. So the core LINK investigators have specific study questions, but the cohort is really meant to give rise to all sorts of different research across various different domains. The 3 key research questions in LINK are outlined here on the slide. So the first is, what is the prevalence of biomedical and psychosocial sequelae of COVID, and what are the determinants of these outcomes? The second primary question is, what are the immunologic characteristics and their determinants of SARS-CoV-2 infection and recovery? And the third is there evidence that individuals who had and have recovered from COVID develop clinical or subclinical reinfection later on? So in the first 6 weeks since our study opened, we've completed 115 visits with 70 unique participants so far. The median age of the cohort is currently about 43 years, and you can see here that participants are drawn from quite a wide age range. The cohort is currently 43% women. The racial and ethnic categories listed here are not mutually exclusive, but the cohort is currently 59% white, 20% Hispanic, 16% Asian, 7% African American, and 3% each Pacific Islander and Native American. And we're really committed to developing a diverse cohort This is a major priority for us, and that also means diversity in terms of degree of illness. So far, about a quarter of the participants to date have actually previously been hospitalized, and we're starting to enroll a few individuals who had asymptomatic infection. Next slide. Thank you. So from these study volunteers, we're developing a really robust biospecimen repository to support various research collaborations. We've already banked thousands of vials of immune cells, plasma, serum, and saliva, and have shared over 1,000 specimens with 12 research groups to date. Link collaborators are currently planning as many as 10 clinically focused sub-studies within the cohort that will further characterize our study participants and do a deeper dive in terms of cardiac, pulmonary, neurologic, gastrointestinal, hepatic, and psychosocial sequelae. So the final point I want to make is that stories like the ones that you've heard are not uncommon within Link. While most people in the cohort have recovered, we're definitely seeing a small but significant proportion of people who have persistent or recurrent symptoms. Aside from Mr. Morrison's example, I can share a couple of other anecdotes. We've seen a number of individuals who are 1 to 3 months out from their acute illness, who've experienced a lot of trouble with concentration and memory that's really gotten in the way of their jobs and affected their quality of life. We've seen a handful of individuals who've experienced kind of dramatically prolonged gastrointestinal symptoms with a month or more of diarrhea or nausea, and those are often associated with substantial weight loss. Another group of participants are complaining of intermittent disruptive bone pain that is really similar to what was described in some individuals in the popular media who were recovering in Italy during their recovery. And the mention of the kind of phantom smell of fire is also coming up in a handful of participants in Link. So it was interesting to hear that mentioned. So, these symptoms don't really appear, at least so far, to strike just a certain type of person. They don't follow a clear age or sex distribution, and they're also occurring across a spectrum of pre-COVID physical activity. So we have people who were like world-class athletes who are really incapacitated now compared to what they were before COVID. And they also don't really cluster in just people who were hospitalized. We are seeing a lot of people who are managed as outpatients who have such symptoms. So one of the goals of the study is to characterize these individuals and determine whether there are biological correlates of these persistent symptoms and what they mean. So I'll end there. We're extremely grateful to our study participants for their engagement in the study so far. And if you are or have a patient with confirmed COVID who wants to participate in research, please feel free to refer them to our website, which is listed on the bottom of the slide, or to our study email, which is also there. And thanks again for the opportunity to contribute to this discussion.
Great. Thank you, Michael. Before I move on to Jeff, do you, either from your study or from the literature, do you have any sense of the prevalence of this? I think most people go into this, I'm very scared that I'm going to get sick and go on a ventilator and die, or I'm going to get better and a month out I'll be okay. So do you have any sense of how many people do have persistent symptoms, let's say more than a month?
I will definitely say that the vast majority of people have completely recovered and are back to their baseline. I think Jeff is going to talk about some of the specific issues with regard to the challenges of studying a population like this in a study of this structure, and how we are working on that within Link, and how the acute and early infection study, our sister study, will really help us as kind of a UCSF research community to achieve that.
Right, well, that's a perfect handoff. So Jeff, it's all yours.
Good, thank you. So Bob really did ask the obvious question. So these symptoms now are clearly documented. We hear them anecdotally. We hear them from expert patients like Dr. Kivlahan and Mr. Morrison. The question now is just how frequent are these? Is this 10%, 1%, 1 in 1,000? Because we need to know this in order to tell patients what to expect long term. But to do it, the only way you're really going to get the right answer is with a representative study population of COVID-2 infected persons, as illustrated here with the green. Next slide. But if you're not careful, it's easy to fall into a trap of getting a biased study population. If you're doing convenience sampling, it's easy to put up a sign for a study like this and get people who are more apt to be experiencing symptoms long term. And so the real problem is that we do not have any large population-based samples of COVID-2 infected or COVID affected persons. Now, this is a problem both for the descriptive work, just how frequent are these symptoms and how long do they last, and for understanding causal determinants, what is behind these prolonged symptoms. Now, a solution that we're developing for this, and this is again work led by the acute study with Dan Kelly and Sugi Lee, is to develop a more population-based approach to recruitment, where we'll begin soon to identify all household-based contacts of newly RNA-confirmed cases, find the incident SARS-CoV-2 infection among these contacts, and then follow them long-term. In other words, really starting much farther left at the population level in terms of identifying a population base of cases developing out of a household. Next slide. What else do epidemiologists think about in terms of the long-term recovery phase? Well, besides these individual level effects, may there be, depending upon the frequency, a population level socioeconomic manifestations in terms of time lost from work or other responsibilities. If COVID-19 does indeed become widespread in the next few years, the population effects in terms of what our expert patients are telling us today could be sizable. Now, another perhaps more academic question is just how much worse is COVID-19 in terms of duration and intensity of these symptoms than other severe acute infections. We certainly know that people who recover from the acute phases of, say, influenza or sepsis are certainly not back on their feet at 14 days. There is certainly persistence in other severe acute infections. So just how much worse is COVID than other severe acute infections? And for that, strategic comparator groups will be needed. Now, we talked about duration of infectiousness in the recovery phase. Do long-term symptoms mean long-term infectiousness? Well, in respiratory specimens to date, there really have not, there has actually not been a report of infectious replication competent virus found in respiratory secretions, say after 10 days worth of symptoms, and that's the basis of some of the current policies on that. But these are not very large studies, and they are not enriched for individuals with long-term symptoms. So I think the jury is just certainly not out on that yet. I might point out that there has actually been a case report in stool specimens of finding live infection-competent virus at 28 days following the onset of symptoms. So I think more work is needed there before we're certain. And then finally, reinfection. Reinfection is common with other endemic human coronaviruses. The big question everyone's asking, of course, is will natural immunity prevent clinically severe reinfection? And so far, there are no reports of someone experiencing a clinically severe reinfection. And if we look at other viral infections, I think we all believe that probably won't happen. But epidemiologically under the hood, one of the most interesting questions, at least to me, is whether or not reinfection, even if asymptomatic, may generate enough replication competent virus in order to transmit to others. So these are some of the things that epidemiologists are interested in the recovery phase of this infection.
Great, thank you, Jeff. Maybe take down the slides, Alyssa, thanks. Are there analogous infections that have been, I guess I'm struck by, this feels novel, and yet with other infections, there probably are people who continue to have symptoms for very long times. Have they been studied with the rigor that you're talking about studying this? If someone has the flu, for example, do we know what percentage of people continue to have symptoms a month out or 2 months out?
I don't think anything has been, I don't know of long-term studies that actually give those kinds of studies. I think anecdotally, we all know that patients are often not feeling, back to normal for many months out. Yeah. I think that we would probably need to do contemporary comparators to really understand that.
Great. Okay, let's turn to Tim. And we've heard people approaching this from more of a clinical approach and an epidemiologic approach, and Tim's approach is more around sort of basic science and what we can learn from the lab. So Tim, take us through a little bit of how you're thinking about this from what you've already heard today and what you've been working on for the last several months.
Sure, thank you. I'd like to start by saying that individuals with COVID-19 can actually present with fairly profound lymphopenia, inflammatory cascades, and generalized immune dysregulation. This is mainly during acute infection, and this is probably the reason that we may see a benefit from dexamethasone or steroids in the setting of more severe infection. Of course, as Dr. Doernberg had said earlier, the jury is still out, but there certainly is exciting data in the right direction. We also see with SARS-CoV-2 that this infection can trigger disorders of hemostasis and clotting, which can lead to severe life-altering sequelae, including stroke. And despite the fact that many patients develop antibodies relatively quickly, usually within 2 weeks for a majority of individuals, there can be ongoing potential immune dysregulation or inflammation that can persist even after a virus is no longer detected. Which also brings up an interesting point that post-infectious syndrome, so clinical syndromes after acute either viral or bacterial infections, are not uncommon. And in fact, they're quite common when we look closely. For example, bacterial gastroenteritis can lead to irritable bowel syndrome that can last for weeks to months, if not longer, or potentially in even more severe cases, Guillain-Barré syndrome, et cetera. So even when the pathogen has been treated appropriately with whatever antimicrobial or the virus is cleared and there's no evidence of replication competent virus, we can certainly see lasting immunologic, autoimmune, or even neurologic symptoms that can persist for, again, weeks to months, if not longer, after some of these illnesses. Now, we don't really understand exactly why that happens. And that certainly is a main focus of our studies and our collaborators as well going forward, to figure out what is going on with immune dysregulation, persistent activation, potential neurologic or other immune deficits that may be more persistent. And to talk a little bit about Dr. Kivlahan's experience as well, it's interesting that we actually do detect in certain instances what we would normally consider acute respiratory viruses that can shed for a long period of time. For example, in immunocompromised participants or patients with, for example, organ transplantation or stem cell transplantation can shed rhinovirus or adenovirus. Many of these are asymptomatic and probably are clinically insignificant and probably don't lead to infection as well, but they can be severe. In fact, we see, for example, adenovirus in immunocompromised folk cause nephritis, hemorrhagic cystitis, even pneumonia or disseminated infections as well, although that's a rarity. So we don't exactly know why, but it's certainly not unheard of for some of these viruses to shed or at least be PCR detectable for a certain point of time after infection. That's not to say that there's replication virus or that there's a potential to spread. I think that's still unknown, but as Dr. Martin and others were referring to as well, it's likely very uncommon that people with viral unshedding, it's very unlikely that they are infectious or pose infectious risk, but again, it's something that we don't fully understand at this point.
Are we somewhere near a commercially available test to figure out whether the patients have active virus? And we hear that in general, the studies show that if you're 10 or 12 days after your symptoms, you don't have active virus. But Coleen's case, she was sort of kept away from patients for a long time, and it would have been nice to be able to actually do a test to figure out whether she does have active virus.
It would be great. You know, we know from the Korean CDC reports, for example, that there are a group of hundreds of patients that they've identified that are PCR positive, which means they have nucleic acids of the virus detectable for months. after their acute infection and onset of symptoms, but there really is no evidence that they are shedding either infectious virus or leading to infectious in others. It's possible that there are non-infectious particles that are being released. It is possible that there are virus is being released but being antibody bound and complexes and therefore unable to engage receptors like ACE2 for infection. And it would be fantastic to have a clinical assay to rapidly look at either infectious or replication virus. I think the challenge there is that unlike PCR tests, which are rapid and relatively inexpensive, these require culturing virus with cells in biosafety contained laboratories, which can be very expensive. It can take quite a bit of time. So certainly this would be a fantastic technology to have. But I think as we go forward, we're becoming more and more confident that several weeks after onset of symptoms, that even if there is PCR positivity, it's unlikely that there is going to be a great infectious risk. But again, we just don't know. And without further study, I can't make a further comment on it.
Yeah, it's tricky because there's unlikely and there's zero, and unlikely may not be enough to allow you to go back and work, take your job in a nursing home or something. The probability has to be maybe pretty close to zero.
Especially if you have high-risk individuals around you as well. Yes, again, unlikely is not zero, for example.
Right. Are the two phenomenon of the virus is enough, there's enough viral replication to cause symptoms, and there's enough viral replication to be infectious. Are those tightly linked to each other, or can they be dissociated?
Well, they certainly are linked, and they can also be disassociated. So the answer to that is both. I would like to mention that in terms of symptoms, a lot of the lingering symptoms that we may be seeing may not be from direct viral pathogenic effects, but some of the downstream immune dysregulation and inflammatory cascades that have developed from that. So you could certainly have persistent symptoms even after there's no replication or viral infection of new cells in the body, for example, that occurs. So that is certainly possible. Although, while they are linked, and certainly there are definitely viral pathogenic effects that cause a lot of the acute damage and symptoms up front, we really think that there's going to be ongoing immune dysregulation inflammation that may be causing not only symptoms, but also some of the multi-organ dysfunction and severe damage we see in those with more severe disease.
And is that testable? I mean, if Cliff came to you today, or I guess he's part of your study, so he has, and he says, I still feel crummy, tell me why, and you say, I can reassure you to a very high degree of certainty that it's not the virus, it's not active virus, we think it might be something with your immune system. Can you tell him that that's in fact true from testing?
We don't know yet. I can say that with PCR testing, we're looking at both the blood and saliva from participants to see if we can find infectious virus, if we can find PCR evidence of viral nucleic acids. And we can certainly say, well, and again, I don't, for Cliff, I don't know yet because this is a research study and we're batching specimens, but it's possible that once the PCR becomes negative, but there certainly can still be immune effects. And I think that's what we're still learning right now. For example, some groups have found that there's an increase in exhausted T cell phenotypes, for example, or continued increases in inflammatory cytokines that can mediate either pro or anti-inflammatory immune responses. And those could potentially cause symptoms and lead to greater longer term clinical effects as well. So I think we're still learning that. And I would have to say that if they're PCR negative, he's very unlikely to be able to infect others. It is likely does not have infectious virus in his body, but there certainly could be ongoing either immune or neurologic effects that are going to persist for some time, but hopefully we'll get better with time.
And the question always comes up about chronic fatigue syndrome and large numbers of people who just feel crummy for long periods of time, decades even, and a lot of controversy over what's going on. When you hear about these folks who continue to feel poorly for a few months, let's say, after a viral infection, does that teach us anything about the pathophysiology of people who have versions of chronic fatigue syndrome?
It certainly has the potential to do so. Although I should say that with chronic fatigue syndrome, folks with chronic fatigue syndrome can have life-altering clinical symptoms, and it's been studied for decades now, and we still don't understand exactly what causes it or even how to treat it for that matter. We know that, for example, treating either viral bacterial infections does not seem to help, but there certainly are a host of a variety of symptoms that persist. And these, again, can severely interact with activities of daily life, but we still don't understand exactly what those are. So I think that we're going to have a similar challenge here with COVID-19, in that we are certainly starting to see some long-term effects, but it may be a while and may take a lot of deep dives with a lot of collaborators in order to really figure out what's going on. So it might take a very long time for us to figure
Maybe
this out.
last question for you, and then I'd love to hear back from Coleen and Cliff to close. I'm struck by both of their stories that the neurological symptoms seem to be maybe the most worrisome and odd. The smell of fire, the cognitive challenges that Cliff is having with his computer and all that. Any sense of what's going on pathophysiologically there? Can you explain that with immune activation or dysregulation, or does that imply something else?
Well, it could be multifactorial, which is what I believe is the case here. For example, we know that respiratory mucosa, including in the nasal turbinates and around olfactory sensors, can certainly be infected, and there can be direct cellular damage that may take a while to heal or repair. So there could be direct viral effects in that. There may be, for example, clotting disorders in microcirculation that can lead to some neurologic deficits. We're seeing, for example, strokes or even myocardial infarction type presentations in people that have with no underlying or little underlying cardiovascular disease, all of a sudden develop these types of symptoms from that. So there could be very organic causes that we can identify relatively easily, but I have a suspicion that there's also going to be, like you brought up with chronic fatigue syndrome, that there's probably a multifactorial process that has to do with a lot of different regulatory mechanisms within the body and the immune system and the neurologic function that will be perturbed in the setting of this very, very inflammatory, very invasive virus that will persist for some time.
Yeah. All right. Well, thank you all. Let me turn back to Cliff and then Coleen to give them the last word. So, Cliff, how are you feeling about all this now? And are you? How did your colleagues and friends sort of treat you? Was there some feeling of stigma during all of this? And were you, how anxiety provoking was all this? Or I'm just trying to get at how it all felt to be you over the last couple of months.
Yeah, it was extremely anxiety provoking. I mean, other than, the other things that have been described, I had unbelievable pain, just all my joints. It just felt like that it was in my bones. And I started having mood swings. I've never really been prone to depression, but I became so depressed that even, people around me were getting concerned, and people were asking me every day, do you feel like you want to hurt yourself? And I was like, no, I just want to die. And then I would have these mood swings where, I would just go to extreme anger and tell everybody to basically F off and leave me alone. Almost felt like, bipolar, except for the fact that I missed euphoria. I just went from, depression to extreme anger. Yeah. And that's gotten better, but it's still, that's still a part of what I'm dealing with. And my concern, and one of the reasons that I wanted to be a part of this study, and I really appreciate everything that all of you have done, and it's been so helpful for me. I felt like people I worked with were like, well, after 13 or 19 days, you should be over this. Why, are you taking advantage of this situation? I mean, I've been off from work now for almost 3 months. Yeah. And so now I've been able, because of the information that I've gotten from being involved in all of this, I'm able to go back and explain to everyone that, yeah, I'm still sick and I am better, but I'm not 100%. So I hope that I'll be able to go back to work at the end of the month, and I'm going to take it very slowly and just kind of ease back into it.
Yeah, well, I'm so glad you're feeling better. And yeah, the issue of stigma and how people treat you about this, and is this all in your head and all that, must be very difficult. I appreciate you sharing that. Coleen, take us sort of, maybe it'll be the last commenter, but sort of the issues of how it felt to be you and feels to be you as you've dealt with this, and you have this sort of unusual position, and you're a primary care doctor for a living, so you've seen this from both sides of the mask. So take us through that.
Thanks, Bob. I would say the most fun thing has been being a citizen scientist in this, is being able to document my own symptoms, to be able to take my own vitals, and now I'm on call every other day for Occ Health, so I get to talk to all of the folks who are positive and hear those symptoms over time. So being a citizen scientist has actually led me to questions that I'll leave you all with. Number one, why me? Why Cliff? Why not you, Michael? Huh? Why not other folks? So understanding the characteristics in the ambulatory setting, number one. Number two, why our partners are negative. And so many of us across the country who have been persistently positive have absolutely negative partners who were our caregivers throughout and have negative antibodies, the most mysterious piece about all of this, despite intimate contact for months. Another one for me is, what do the viral cultures really mean? And is that where we're going in the future to be able to become reassured about our lack of transmissibility? The emotional factors are exactly as Cliff describes. A is living with ambiguity and fear. What does this mean? Am I going to get it again tomorrow? Every time I walk by someone smoking and can't smell it, and yet I can smell like I'm in the campfires in Northern California, reminds me about the ambiguity of how little we really know about this yet. The second is future impact. I'm incredibly healthy, started incredibly healthy, still am incredibly healthy. I'm blessed about that, but wonder about my heart, lungs, and brain. And the third is stigma. And it's given me, not the first time in my life, I've had malaria and many other infectious diseases with my travels, but this stigma of people not willing to see me, even though I have a mask and even though my PCRs are negative and I have antibodies, not willing to be close to me in any way, not willing to touch. So the stigma of wondering whether I can be as effective as a physician and as a human being as I was before is a real question. And the ability then to recognize what's happening with our Black and brown brothers and sisters with COVID all over the country, who have the stigma of race or the stigma of poverty or the stigma of this illness, is an opportunity for all of us to get better and smarter. And I am deeply grateful to be at UCSF with the commitment to thinking hard about these issues and creating now new studies in the ambulatory setting and moving beyond just that few percent who are in the hospital. So thanks to you all.
Well, thank you to all of you, and maybe particular thanks to Coleen and Cliff for sharing your story. That's not an easy thing to do with this public and audience, but you have made us all smarter and more sensitive to some really important issues that is just emerging in the last few weeks. And I think it's going to be increasingly important for us to understand them, and grateful to Jeff and Tim and Michael for studying it, and all of your colleagues, because we all need to get smarter about this. So let me sign off and thank our crack production team, who always put this together flawlessly each week. Thank you to all of them. As I mentioned at the start, next week I'll be interviewing John Barry, the author of The Great Influenza. It's a terrific book. If you have an opportunity to read it, it will demonstrate that some of this is new and some of this is very old, and there are many lessons that we can glean from history. I think we'll take the week off after that, the week of the 4th of July, but be back a week after that on July 9th. But next week we'll be on with John Barry talking about the Great Influenza and the lessons from the 1918 pandemic. Until then, I hope everybody stays safe and stays well, and thanks for joining us.